welcome everybody. Good morning. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm Yaron Ivan, your host, and today I'm going to talk about my approach to a patient with a rash in the Pediatric Emergency Medicine department. So this is actually a lecture that I put together a while back, and I've given this lecture to the Pediatric Emergency Medicine and Family Medicine residents, as well as my PA and my PA students. And it's really a lecture that was inspired by them. I often work with a lot of trainees, and many times when they sign up to see a patient with a rash, they kind of preempt me, Dr. Ivan, I'm about to see this kiddo. I'm not really good with rashes. I may need your help, etc. I may need you to go and see him. Of course, I'm going to go and see him. They sound very hesitant and they have very little confidence. Many times after they see the child, they present it, and they're often very hesitant and sound very concerned. You know, Dr. Ivan, I'm not really sure what this rash is from. I don't really know what he has. You got to see it. I really don't know. And I find it interesting that they do that because oftentimes when they present a child with, let's say, abdominal pain, especially the senior residents, they're often very confident and they say something like, you know, Yaron, I don't know why this child is having abdominal pain, but it really doesn't seem to be surgical. I certainly don't think he has appendicitis. I don't think he has a surgical abdomen, and I think he's okay to go home. And I encourage them to think the same way about a child with a rash. In other words, go in there, look for the red flags, and if the child has none of them by history or exam, it's okay if you don't know why he has a rash. You just need to know, you must know, that the rash is not secondary to a life-threatening or serious condition. Remember, one of the PEM rules is you're not in the business of winning, you simply don't want to lose. Just like you don't know what the abdominal pain is from, and you're okay with it, as long as you know it's nothing serious or surgical, you do not need to know what the rash is from. But you should know, you better know, that is not secondary to a serious etiology, something like Stephen Johnson's comes to mind. So that is really how I think about all my patients. Again, I'm not in the business of winning, I just don't want to lose. I go into the room in every encounter looking for the red flags by history and exam, and if there are none, I apologize to the parent and I explain, Mom, Dad, I'm not really sure why little Johnny has this rash, but it doesn't seem to be anything concerning. It doesn't seem to be anything serious. I think you can follow up with your primary care and little Johnny is probably going to be fine. Now, the way that I do that is by knowing all the red flags for a rash, just like I know the red flags for abdominal pain. So again, my residents know very well that if they see a child with abdominal pain, they're very familiar with the red flags. So if the kid has right lower quadrant pain, they know that's not good. If he has significant nausea and a lot of vomiting, they know that's a red flag. If the patient has peritoneal signs, rebound, they're unable to jump, because every pediatric patient with abdominal pain must jump, they all know those are bad signs, red flags. And they're very good about putting together the differential diagnosis when they see those red flags. I think it's very helpful to approach rashes exactly the same way. Now, to do that, you also have to know what the red flags for rashes are. So that's how I think about it. Now, before we get into that, I think it's very, very important to remember when you see a child with a rash, you really have to do several things. Number one, you got to touch it. You want to know if it's tender to the touch. You have to feel what it feels like so you can describe it in your notes. And you have to see if the skin is intact. You have to know if there's a positive or negative Nikolsky sign. We'll get to it later. And very important, as you probably know, most rashes in kids involves some erythema, and you got to make sure you know and document that it blenches on pressure. So you really have to touch it. So it's very, very important. Wash your hands, put your gloves on, and touch the rash. The other thing that I often do with rashes is I really look up close. My favorite example is when I see small papules that I think are secondary to molluscum, I literally take the otoscope and use it as a magnifying glass to look up close, looking for that central umbilication. And if I see it, I make the diagnosis, no big deal, give the parents some anticipatory guidance and send the child home. So again, touch it, look up close, and most importantly, look for the red flags on physical exam. So what are those red flags on physical exam? Again, just like you know the red flags for abdominal pain and most other presentations, you gotta know the red flags for a rash. And if you do, hopefully you'll be able to rule out any serious etiologies of a rash or any life-threatening conditions and have the right disposition for the patient. So what are those red flags? Number one, which is probably the easiest one to find and easiest one to identify, is if the child is ill-appearing. If the child is ill-appearing, it really does not matter at all what the rash is. If the child is ill-appearing, I'm going to be very concerned, get an IV, resuscitate the patient as needed, give fluids, treat the symptoms, etc. Maybe I'm probably even going to admit the child. So it's kind of obvious if the child is ill-appearing with any sort of rash, that's a red flag. You got to take care of business. The second red flag that I think about is if the rash doesn't blench. Like I said, you got to touch it. So anything that is petechia or purpura, in other words, doesn't blench, is somewhat of a red flag. Again, sepsis comes to mind, HSP, which is not necessarily a serious rash, but you got to do some workup, namely a UA. We'll talk about it. So look for that blenching. What I do usually is kind of stretch the skin and look for the red spots to disappear. The third red flag that I often think about is if the rash is vesicular. So when I look at a rash, I look up close and I touch it, I want to make sure it's not vesicular. Vesicular rashes are for the most part somewhat of a red flag. So again, HSV comes to mind, for example. That is something that I need to know about, that is something I can treat. So look for that red flag. Look for the vesicular nature of the lesions. The fourth red flag that I think about, also very, very important, is if there's any tenderness. Like we said, we're going to touch the rash, and if it elicits tenderness by touching, to me, that's very important and that's a red flag. For the most part, the benign rashes such as hives and viral exanthem, which are my favorite examples for benign rashes, they don't really hurt when you touch them. So anything that elicits tenderness, I think maybe cellulitis, again, Stevens-Johnson syndrome, that's something that I want to know about. That is obviously a red flag, and you also got to document that. Another red flag that I think about is a positive Nikolsky sign. And if you don't know what that is, that basically means that the skin is kind of sloughing off or falling apart when you touch it. That's obviously very, very concerning. Big red flag. That should not be happening with any of the benign rashes. Again, viral exanthem comes to mind. The next red flag that I want to think about, very important, is the involvement of mucous membranes. Oftentimes, involvement of mucous membranes translates to oral pain, can lead to dehydration, and that's certainly a red flag for me as a pediatric emergency physician. And again, when you think about the benign rashes like hives and viral exanthem, they really never involve the mucous membrane. So any mucous membrane involvement is somewhat of a red flag. And the last one is involvement of the palms and the soles, especially on the palmar aspect. Again, when you think about the viral exanthems and the hives, they really rarely involve the palmar aspect of the palms and the soles. So anything that does that makes me think, maybe I'm missing something, maybe there's something more serious. So again, reviewing those few red flags. Number one, if the child is ill-appearing, not good, big red flag, you got to take care of business. If the rash doesn't blench, meaning it's petechia or purpura, that's a red flag. If the rash is vesicular, you got to think about HSV and possibly treat it. If there's tenderness to palpation, maybe cellulitis. And if there's a positive Nikolsky sign, not normal. If there's mucous membrane involvement, think about oral pain and possible dehydration. And if there is involvement of the palms and the soles. Now, those are the red flags that I think about on physical exam and history. On the other hand, I also would like to look at and document if there are any reassuring signs or anything that makes me less worried. So, for example, any rash that blenches, for the most part, I'm not particularly worried about. Again, I think about allergic reactions, bug bites, or viral exanthems. Those usually blench on pressure and are very, very reassuring. So, like we said, you got to touch the rash and make sure it blenches. And as usual, if the child is very well appearing, happy smiling, sitting up in bed with a positive popsicle sign, that's a very reassuring sign. And that's something I often document. It really doesn't matter what rash he has. If he looks so good, that's a very reassuring sign. Now, I do want to make something clear. Don't get me wrong. I don't want you to think that if you see any of those red flags that I mentioned, it means that the child needs a workup, admission, calling the ICU, or anything like that. Not at all. And let me explain what I mean. So, for example, If I see a child with petechia and purpura, mostly petechia, let's say on the face, under the eyes, and mom is telling me he's been coughing really badly in the last week, I can understand that. That's okay. If you're coughing really badly and you have a little bit of petechia on the face, again, assuming your lung exam is normal and you look well, I'm not particularly worried about those petechiae. So I document that and I make sure the child is well otherwise and I send him home. Another example is during the spring, especially when we see a lot of hand, foot, and mouth disease and herpangina. That is a vesicular rash. That is not a serious disease, however, but it does make me think twice before I send the child home. So if I'm concerned about herpangina or hand, foot, and mouth disease, you have to really sit with the mom for a good 5 to 10 minutes and give appropriate anticipatory guidance, explaining that really the only risk with that rash is if the child is not drinking and gets dehydrated. You want to tell the mom that the rash may look terrible, but if the child is well otherwise and drinking, there's really nothing to do. You may want to warn the parents that in a week or 2 or 3, the nails may fall off, which looks terrible, but that's okay. So again, if I see vesicular rash and I think it's hand, foot, and mouth, no big deal, but that does involve a few minutes of good anticipatory guidance and make sure mom and dad follow up with the primary care. So keep in mind, guys, I'm not here to win. I just don't want to lose. I don't want to send the child with early Stevens-Johnson syndrome home, just so he comes back with some serious complications. So I go in the room looking for the red flags of rashes by history and physical exam, and if I see none of those, I simply provide reassurance, maybe a referral to the dermatologist, and I move on. I think it's very helpful to simplify the process and not go in there thinking, oh, I need to find the etiology for the rash. I better find an answer. You don't have to find an answer, but as a pediatric emergency provider, you got to make sure the rash is not secondary to any serious underlying cause. And again, Stevens-Johnson just comes to mind, or maybe Dress syndrome or one of those. And that's it for today, guys. Thank you very much for listening. I hope you enjoyed the episode. Feel free to check out pemrules.com, submit any feedback, or even make requests for future episodes. I would love to hear from you. I hope you enjoyed the show, and I hope you tune in next time. Thanks very much, and have a great day.